Hello everyone, welcome to the CCS cases. Our case today is very interesting. A patient present with abdominal girth, early satiety, fatigue, weight loss, bloating, anorexia. What do you think is the differential diagnosis for this case?
So I'm gonna go with the liver cirrhosis first,
Mm-hmm.
and because of the ascites and bloating and fatigue, it might be CHF exacerbations or any malignant disease.
Okay, yeah, it could be cirrhosis. So there's like a swelling. So it could be failure of the heart or the liver or cancer. Mostly ovarian
Mm-hmm.
cancer. So pelvic ultrasound, the most important thing. Okay. So what's the pre-operative workup for ovarian cancer?
It's a cancer 120 C8 125 marker and ultrasound.
Okay. What else? We want to stage it. So what do we do to stage it?
Yeah, we do chest X-ray or CT scan of the
Perfect.
pelvic
Yeah.
and chest.
So the CA 125, we do abdomen pelvic CT plus chest X-ray, and then we do limited diagnostic testing to exclude metastatic. So what do we do? So just to exclude metastasis. So what do we do? How do we exclude
Yeah.
that it's not metastasized?
Okay. Beside the CT scan
Mm-hmm.
of the chest, abdominal pelvis, we do like we try to exclude colon cancer and by like a fecal occult blood or colonoscopy, and we do pap smear. Okay, and we might also consider um, upper GI series.
Okay, perfect. Yeah, so we do colonoscopy, FOBT, pap smear. We consider upper GI series. We can do endocervical curettage if we suspect endometrial cancer. Okay, and
Mm-hmm.
we obtain biopsy of the peritoneal tissue if there is the diagnosis unsuspected, if it's uncertain. Sorry. So what do
Mm-hmm.
you do after that?
Well, if there is like if it's positive, so probably we will gonna start the patient. We were gonna consult first the gynecologist, okay, for like unexpected surgery, and we were gonna start preparing the patient for surgery, like preoperative measures, like we obtain the blood group and cross match, and we keep the patient in BO. We do EKG and coagulative studies and CBC, CMP, and we start him on antibiotics prophylaxis.
Perfect. We consult gynae and we do the NBC pipette. NBC pipette. This is for any surgery. So this is the mnemonic will already take care of it, which is NB. So NPO. The B for blood and cross matching. We'll come to it.
Mm-hmm.
Okay. So what do we management? What is the management for ovarian cancer?
It's usually a surgery. So, but it's a surgery. It can be laparoscopic also. Okay, but we usually recommend the laparotomy because we have to do like we might also find metastasis to the adjacent structure, so we might need to do like complete hysterectomy plus oophorectomy and some.
Yeah, perfect. We can do
Uh,
cytoreductive surgery, or we
mhm.
can do the we can do it through laparotomy. Okay. And why do you think the laparoscopic resection of ovarian cancer is not recommended?
Yeah, as I mentioned, sometimes the cancer is already metastasized to the adjacent structure, so doing a laparoscopy alone it's not sufficient sometimes.
Yeah, perfect. Yeah, and we consult oncology for adjuvant palliative chemotherapy. Okay,
Mm-hmm.
we can do the carboplatin plus paclitaxel, but we usually don't go through that like with the CCS case. So okay, CCS case is very easy initially. So there are timing, timing important. CA 125 should be obtained before surgery. This is number one, very important. And the pre-operative can be done outpatient and or inpatient. We can do the test. But when we want to do surgery, we have to admit the patient first. We do the V-panic, and then we do the surgery. Okay? So initially, we do complete physical exam. We do the catagleam plus pelvic ultrasound. And the ultrasound confirmed that it's an ovarian cancer. What do? We do for staging. So the first one, catagleam plus pelvic ultrasound. Catagleam, the same one we discussed, mnemonic. Plus pelvic ultrasound. And then once the ultrasound confirm it's a cancer, then we do for staging. This usually with any cancer. Cancer is very important, very high yield for the exam. So after we do the pelvic ultrasound, we do check for abdominal CT, CA125, chest X-ray, colonoscopy, mammogram, pap smear, EKG. Okay? So this is the staging. And then we do the NBC pipette before surgery, which is NPO, admit first. NPO, blood and cross matching. We consult gynae and cancer diagnosis counseling, PT, PTT, INR. Okay? And usually gynecology will take it from there. They will do surgery. So it's usually case end at this moment. If not, then just follow up in 1 week. So you see, this is with any cancer. Usually you do the catagleam. Most cancers, let's say. Catagleam, which is CBC, CMP, UA, TSH, and G glucose, L lipid, ESR, EKG, and magnesium phosphate. You can do them, not all of them. You can do it. Pick the important one from them. Catagleam plus pelvic ultrasound, and then after that you screen for metastasis. How do you screen for metastasis? You do chest X-ray, CT in the area, like CT of the abdomen. You do tumor marker. This is based on medical knowledge. You can't have a mnemonic for that. You do the screening too. Like if after more than 50, you do mammogram, colonoscopy, pap smear, EKG. Okay, all these good stuff. This is the second step. The third step is that we do NBC pipette. NBC pipette is what before surgery. And for NPO, we do NPO, blood and cross matching. Okay, and then we do PT, PTT. Okay, consent, we take consent, and we consult surgery and OB-GYN. Okay, after that we just let the OB-GYN take it from there, and the case end usually at that level. Okay, and that's the ovarian cancer. Okay,
Thank you
so much for listening, and we'll see you on the next one.
Thank you.